be recorded.
At this time, I would like to introduce you to our speakers, Eric Schell and Terry Hill. Terry Hill is the Executive Director of Rural Health Innovations, a subsidy of the National Rural Health Resource Center. Terry was the center's former president and founder and acts as the center's senior advisor for rural health leadership and policy. Terry has more than 30 years' experience in rural health care and has worked with community leaders, hospitals, and networks across the country. He is a featured speaker at rural health conferences, has published dozens of articles, and served as board member for numerous organizations, which currently includes the National Rural Health Accountable Care Organization. Mr. Eric Schell has over 25 years of experience in healthcare financial management and consulting. At Stroudwater, Eric assists rural hospitals across the country with improving financial and operational performance and developing strategies and operational plans that now particularly focus on transitioning to population health. Eric is also a featured speaker at rural health conferences and currently serves on the National Rural Health Association's Rural Health Congress and Governmental Affairs Committee. All right, and at this time, I will turn it over to our speakers. Just a reminder, Eric.
Yeah, thanks, Nicole. Are the slides going to go up? There we go. Fantastic. Well, thanks for the introduction, and I'm looking forward to giving this presentation. Good afternoon, everyone. Happy Friday, and let's get going. We've got about 40 minutes to get through about 2 hours worth of discussion, so it's important to move. Many of you have seen versions of this presentation before, really looking at three pieces. One, where is the healthcare industry moving and why? And it's the why, that understanding that is really important. The second is what's the unique value of rural hospitals in this new world? And then the third part of this presentation is if the world is moving, if the environment's moving in this direction, if rural hospitals have this very unique value, then how are we going to get there and to get there successfully, recognizing some of our kind of fee-for-service limitations at this point. So kind of with that as an overview, let's just get this thing rolling. Trying to get it the page down. Oh, there we go. There we go. So the healthcare industry for 30 years have lived in this world of fee-for-service. Price, what you get paid, times your volume, your units of service that you can generate is your revenue. And really, over the last 5 years, increasingly, there's been all kinds of pressure on primarily the volume piece of that, and it's emerging, and it's merging quickly, but also on the price piece of this. And some of the things that I want to point out here, and just kind of this high-level market overview, was kind of where are some of these attacks coming from. I think if you've heard Brock speak at the NRHA, I think some of these are going to mirror what he has to say. The high deductible health plans and the impact that these plans are having on turning patients into consumers. The fact that these health plans are often seeing reductions in premium, which ultimately means kind of reduction in amounts paid to you, much of which is gained through utilization declines. The state budget deficits and how states are responding. Some states are very progressive, moving to, like in Alabama, that's moving to 11 regional care organizations where, sometime in the next year or two, the state is going to hand out 11 checks to 11 provider-based organizations to care for their Medicaid patients in their service area. Some states are just going back to managed care 101, 1992 circa, and hoping the gatekeeper model is going to help them. You'll see why I frown upon that. Recovery audit contractors, reduced readmission, the shift to outpatient care, MACRA. I'm going to hold off on that for now because I got 2 slides just to talk about MACRA because this is big. The comprehensive pay model. I was in Iowa 2 weeks hearing a presentation on the impact that this could likely have on critical access hospitals, an attack on many of our swing bed volumes as those communities in the 67 MSAs that are part of the comprehensive joint replacement model kind of move to reduce their bundled costs. The continued attacks on 340B from the big industry, the pharma lobby. All of these things kind of are teaming up many of which to take out the volume side or reduce volume from the price times volume is net revenue calculation. Just a slide on MACRA. The more I understand and travel around the country and listen to speakers talk about the increase, the implementation of MACRA, this was the bill to fix the physician fee schedule, the sustainable growth rate in the physician fee schedules. It was a bipartisan effort that was passed in last April, just over a year ago, a year and 2 days ago. And increasingly what the market is saying is that this is, anybody thinks that throwing Obama out of the office, we're going to go back to kind of, we're going to remove some of these ACOs and these alternative payment models that are coming down the pike. That we're going to have to put that myth aside, because the MACRA was a joint Democrat, Republican, bipartisan bill that was passed that ultimately kind of is forcing physicians, not forcing, but really persuading physicians to move into one of two tracks. And so what's happening is from 2016 to 2019, there's going to only be a 0.5% increase in their fee schedule when their costs are going up higher than that, especially with the implementation of electronic health record and the reduction in efficiency that's had within our practices. The second piece, and this is where the things get interesting, is beginning in 2019 through 2025, physicians are going to be, there's two tracks they can take. They can either elect to be in these alternative payment models in which they immediately get a 5% bonus, and then they will be subject to the bonuses and incentives built into these alternative payment models, which you're looking primarily at accountable care organizations, patient-centered medical homes, bundled payments. All of these are considered as part of these alternative payment models. If a physician payer mix is not at a certain threshold of these alternative payment models, they're going to be thrown into this second category, and it's called the Merit Incentive Payment System, MIPS, as people are talking about it. And MIPS is actually saying, look, we're going to benchmark all physicians. If you have a provider number as a physician, you will be benchmarked across the country, and you will be given one score. And that score, you will be compared to all other physicians, and that score is going to be based on four categories. How the physician uses resources, interesting because that really hasn't been defined yet, their adoption of electronic health record, their PQRS quality scores, and then clinical practice improvement. So those four areas are going to come on there. There's going to be a score assigned to the physician, and the physician, depending on how they score, high or low, could have huge increases in their fee schedule, and anywhere as this thing rolled out to upwards to 15% decline in payment up to significant positive amounts. What we're hearing in the industry is that physicians in the know on this are ultimately saying, hey, look, well, first of all, the ones in the know, asterisk that comment, because a whole lot of physicians, I gave this talk 2 months ago up in Alaska, and there was 20 physicians in the room, and they had never really even heard of MACRA. And so anyway, the physicians that are in the know are saying, hey, we really don't want to be kind of cast into this this benchmarking system where we could suffer significant penalties. And so we're going to be looking to move to these alternative payment models. The second thing is that for the hospitals that at this point don't have, that employ a number of physicians that don't have a population-based payment strategy in place, we've got to start designing criteria into our incentive compensation arrangements now to get ready for this new thing. So because if this rolls out in the end of 2019, probably the benchmarks and how we're going to start benchmarking physicians is data that's going to start to be collected in 17 or 18. Anyway, MACRA is a big deal, and it's really going to be, I've heard, I was speaking with a physician yesterday in South Carolina, and this physician said he thinks this is as big, this MACRA is as big as the Affordable Care Act. So I did want to spend 3 or 4 minutes on that just because of how big this is going to be. But overall, those adjustments, what we're seeing, these changes in the marketplace that we're seeing are really attacks on this pillar of price times volume as net revenue, and primarily around the volume. There's another slide here. Slide 4 is really just additional detail or additional information for you all to have as it relates to specifics of the macro. So just going forward, a couple slides on healthcare reform and the Affordable Care Act. Passed over 6 years ago. This thing's been in place. I look at it having 3 impacts, large impacts on rural hospitals and rural communities. First, more people with insurance, and some states that have expanded Medicaid. I was in Arkansas on Tuesday, and their uninsured rate, a Gallup poll that was conducted this summer, showed that their uninsured went from like 22% to like 7%, or some ridiculous, 13 or 14% decline in the uninsured with the adoption of the Medicaid. Even states, I was speaking in South Carolina yesterday, and even that state that hasn't expanded Medicaid, their uninsured rate went down from about 18% to 12% just through some of these other things. So a couple points were there. Ultimately in rural, it has been documented as having a higher percent of under and uninsured. More people with insurance. We're going to have a much more interesting marketplace for others. The larger hospitals that are kind of their volumes are getting squeezed. So that's kind of the first piece of Obamacare that's relevant. And the second piece of Obamacare that's relevant is the government said, hey, we're not just going to pay for, or actually, what we want to do is we want to pay you less than your costs are going up. All right? So and it has to do with these update factors, and where the update factors are going to be adjusted down for productivity, and then another % down because we're the government and we can. And so what's happening, if we go back to that model of price times volume is net revenue, when price is going down less than cost, to maintain that revenue, somebody's going to have to increase volume. But we just talked about volume and the market conspiring to take out volume. So now we're kind of things are getting more challenging for us. And so I look at this and oh, by the way, this idea of price going up less than cost, that's before all of these other cuts. So this is a little difficult to read, but between the declines in the Medicare DSH payments as more and more people come on the rolls of insured, the Medicaid DSH programs, meaningful use programs are going away. This is the last year of meaningful use incentive payment before the penalties kick in. All of these are additional monies coming out over and above this price going up less than cost. And being the kind of the left side of this equation, price times volume is net revenue. So how does this look in regulations? It's interesting. This was the CMS came out with the final regs related to outpatient payment for PPS, larger hospitals, in October. And you can read the whole line, but essentially what I've circled is the final rate update will be minus 0.3% for fiscal year 2016. And it's funny, but how many of your costs are going up minus 0.3%? So interesting how this is being played out in the market. And what this is saying is that these payment changes are going to increase pressure on margins and really force competition. And frankly, what I'm looking at is seeing that with more people in rural having insurance, with the competition in the big cities heating up, and this force to those organizations that are staying in fee-for-service, is they're looking to come out and get market share, and rural right now is pretty ripe for that. The last piece of Obamacare is that I think is relevant. So more people with insurance. The second one is price relative to cost is coming down. The third piece is this right here that says the government says, hey, we're not just going to pay for our volume anymore. We're going to tie some quality strings to it. And all of these things that you'll see. And then they threw out this concept of the Accountable Care Organization, and you can see the definition. The Accountable Care Organization, the ACO, is really a movement towards population-based payment through budgets. And so it's away from fee-for-service towards population-based payment methodologies. And when the regs originally came out of these things in 2011, the market's response was these things are not going to see the light of day. It's not going to work. And then since the regs, the final regs came out on ACOs in September of 2011, the market was wrong on this one. Right now, as of 2016, we have nearly 500 Medicare ACOs, 8.9 million Medicare beneficiaries. 25% of total Medicare fee-for-service beneficiaries are now in an ACO. Fascinating. And you see they're all over the country. I was in Alaska last week. It's right now. It's one of the, looks like only 3 in the United States that don't have an ACO right now, and so just interesting. But all the rest of the country, this is one that you would have thought probably the southern states, maybe they wouldn't have gone. This is just one of these Washington, D.C. things. That's not the case at all. We've got some accountable care organizations coming up all over the United States. Just last month, Health and Human Services pushed this out. Originally back in January of last year, 2015, Sylvia Burwell, the director of HHS, came out with a statement saying we want 30% of Medicare payment in an accountable care organization by the end of 2016. Well, the news release that they just published last month said they've already hit that 30% at the beginning of this year, a full year ahead of schedule. So this thing is flying. And now you're saying, okay, well, the market said these weren't going to fly. The market was wrong. Why was the market so wrong on these things? And that really came out of a model. I was working with 4 critical access hospitals in northern New Hampshire, and it was a population. They were interested in moving towards population-based payment. A lot of hospitals here in the Northeast are looking, and especially in New Hampshire, Maine, are in some form of an accountable care organization. So these 4 hospitals in rural New Hampshire wanted to kind of take a look at this. If they were to come together, what would that look like? So the first thing that we did is we looked at we built this financial projection, a 10-year projection of their financial performance, maintaining fee-for-service, making some assumptions around continued reductions in inpatient care. In Blue Cross New Hampshire pays the beneficiaries $250 to leave rural communities to get their surgeries in ambulatory surgery centers in Concord. So we factored in a number of these cuts that we talked about on that second slide of this presentation. And what happened was it became the holy cow scenario. The combined financial performance of these hospitals looked like this. On the left is operating income. On the right is their consolidated cash position, which was just getting destroyed. And so what happened, and what really became clear to me is the reason why we're seeing this incredible growth in the ACOs is that the hospitals are looking out. Anyone that's looking out between a 1 or 2 year budget cycle is looking out to this fee-for-service world where price is going down relative to cost, where volume is coming out of the system, and are looking out and saying, this fee-for-service dog ain't going to hunt for long, and we really need to think about changing the payment system. And so, providers are taking the lead in this. I was in South Carolina yesterday, and somebody said, well, is this just one of these government things that are being pushed down? Nah, not really. This is, or provider organizations are taking the lead. And here's an opportunity to, in most cases, on a gain share only, not having to take risk, get into a payment system, a population-based payment system, and explore what it means to their organization at no risk, other than the risk of the cost of the setting up the ACO. And so providers are taking the lead in this movement. Those organizations that haven't responded, kind of what's the fallout from the organizations that haven't responded to this price coming out, volume coming out, and not moving to these new payment worlds? Hospitals are closing. I think the NRHA, this is something that the Shep Center down in North Carolina publishes, keeps on track, real time on. What's interesting is you'll see that there were 71 rural hospitals closed since 2010. The last time I updated, I just updated this presentation back a month ago, and the last time I had pulled data, it was from August of 2015, and there was only, I believe, 56 rural hospitals that had closed through August of 2015. So, we do the math here. We've had 16 rural hospitals close here in the last 8 months. The trend is absolutely frightening. And I know the NRHA is doing a pretty good job of getting the word out there that we've got to stop this. And you can see where a lot of the closures are occurring in states that have not expanded their Medicaid. That's the red. The blue are the states that have expanded their Medicaid programs. So anyway, we've moved into this new world. The challenges that these were defined by a work group in Louisiana of CEOs of rural hospitals in Louisiana, about 4 years ago. They said, boy, challenges that are affecting us today really are these payment systems transitioning to a new population-based system. We don't really know how to deal with that. Quality, which used to be kind of a back office, is now people that are doing it well. And let me just qualify quality. Let's say it's the game of quality measurement, because we haven't really truly figured out how to measure true quality. But people that are doing the game of quality measurement great are using it to compete with other organizations. And frankly, the payments are reduced payments are real this time. Interesting, I got to hear Don Berwick on Wednesday in South Carolina speak at this conference, and what was interesting is what the hospitals have said, kind of what's new, how has the market changed, is essentially Don Berwick's concept of the triple aim: population payment, population health, quality, and efficiency are the 3 points of Don Berwick's triple aim. But it's a market competition over the triple aim. And I was asked to speak at a ACHE conference several years ago in Mississippi, and they kind of wanted me to talk about the rollout of the triple aim in rural healthcare. And what was really interesting is what hit me is those things that have just recently come on as the challenges rural CEOs are dealing with is a market competition on the triple aim: population health, quality, and efficiency. And as I started preparing my thoughts for this presentation in Mississippi several years ago, it hit me that the most profound article I've ever read in healthcare was this Michael Porter, famous Harvard economist. He wrote an article in 2004 called Redefining Competition in Healthcare, where in this article he said competition is not the root of the problem. What we've been competing on for the last 30 years is the root of the problem. We've been competing on the zero-sum game of shifting the buck between providers, insurers, and patients with no fundamental impact on the biggest economic driver. And Michael Porter said in this article, when we start a market competition on the biggest economic driver, we are going to see costs come out, innovation come in, like any other highly competitive industry. Well, in this article, he defined the biggest economic driver as patient value. And if we link patient value to Don Berwick's definition of patient value, population health, quality, and efficiency, we're there. We've started a new market competition now on patient value as defined by the triple aim. What come into this bloated, sick care, oversupplied industry is going to go through a meat grinder, and what's going to come out is something highly efficient and very innovative, and that's kind of how we see this thing coming out. So, anyway, if patient value is the new equation, then what we've got to look at is quality over cost times the population applied to a population. Anything that increases quality, holding cost constant, improves patient value. Anything decreases cost, holding quality constant, applied to a population, increases patient value. But ultimately, it's this equation right here is what we're going to. This is the new economic. This is the economic driver that we're going to be competing on. So let's very clearly understand it. And again, the quality, I will qualify that and say, we have a $3 trillion industry that's going to figure out how to measure true quality, i.e. patient outcomes. And we have yet to do that, but with $3 trillion at stake, we're going to figure that out as an industry over the next 5 years. Let's be very clear about the difference and differentiate accountable care from managed care. I think managed care failed for all the right reasons. I think accountable care, which is a mechanism where providers monetize the value from increasing quality and reducing cost. So think about that. Where providers, the payment system, where providers monetize the value of increasing quality, reducing cost to a population. Think of it as anything from bundled payments, value-based payment program, your own self-insured health plans. If you come together and improve quality, reduce cost, you monetize that value. Medicare ACOs, all of these are accountable care payment systems. And it's different from managed care. If you think about who monetized the value of increasing quality and reducing cost in the managed care era, It was the insurance companies with probably the littlest ability to affect that other than managing costs through denying claims and cutting payment through strong negotiating tactics. The incentives were all wrong in the managed care era. It's different now. When providers monetize the value, the incentives are finally in the right place. The second thing that I think that it's different this time, and accountable care payment systems are here to stay, is the government's all in. Back in the managed care era, we were doing all of this capitation, gatekeeper, all this stuff for what, 15 to 20% of our payer mix. Well, that's not the case anymore. Government's all in this new world, and especially with the states that have moved to these accountable care payment systems. We've got new information systems. We've got a body of science now where providers hold themselves accountable through evidence-based protocols. And frankly, going back is not an option. We've gotten so expensive as a healthcare system at marginal quality that we've priced all non-healthcare industry-related industry essentially out of business in a global economy. And we've got to get this thing right on behalf of our entire society. So, that's kind of where the market's going. I think this is the new word. I think this is the new language. This is how we have to start thinking, especially as rural providers. And now I think rural hospitals have incredible value in this new world. And the value the rural hospitals have, frankly, is that, and this struck me, this became very clear back in 2011 when I was reading the regs related to the ACOs. There was one line in the regs that just jumped right out at me, and it said something like this. It said, a primary care physician can belong to one accountable care organization. Hospitalists and specialists can belong to multiple accountable care organizations. That one line told me everything, the accountant in me, of course, told me everything we really needed to know about cost centers and revenue centers in the new world. You can only assign revenue to your income statement once. And so what we were looking at here was primary care physician could belong to one ACO, i.e. the patient is attributed in most cases to a primary care physician, and a primary care physician has to pick an ACO if they choose to be in an ACO. And so rural hospitals that have tight alignment with their primary care physicians, frankly, are the revenue centers of this new world. And that's what this slide is really saying. To the extent we have strong alignment with our PCPs, we're relatively efficient and high quality, we have incredible value in the world of alternative payment models. Just a quick illustrate, compare and contrast fee-for-service from population-based payment mechanisms. Think about let's talk about fee-for-service first. In a fee-for-service world, you've got two lines, right? So you got your x-axis is volumes, your y-axis is dollars. Your cost line, we have high fixed costs within our industry. Think about our patient parking lot on a Monday morning at 8 o'clock versus our employee parking lot. That is low volume, high cost, but for every incremental unit of volume that we generate in a hospital, our costs go up a little bit. Our revenue line is much steeper. Every incremental unit of volume, whether it's emergency room visit, it's one more patient overnight, our revenue goes up, say, $1,500 for that patient overnight. Our cost might go up $200. And so the goal in a fee-for-service environment was to push out volume to get so this much steeper revenue line would catch and surpass the very shallow slope cost line. Basic economics. But there was another strategy that fee-for-service, how to maximize fee-for-service, and it was to increase the slope, move the orange line to the left. And the way that we could do that is things like neurosurgery, cardiothoracic surgery, and so we start thinking about this fee-for-service world, and the organizations that maximized that were really the larger urban systems. Now turn the equation upside down. Let's move to a population-based payment system and think about that. In order to increase our revenue, we've got to add population. In most cases, a population is attached to a primary care physician. Let me give you some numbers. Last year, the average per capita healthcare cost in the United States was about $10,000. If a busy primary care physician panel of 2,000 patients was in a population-based payment world, that future economic value of that practice is somewhere around $20 million. Rural communities that are aligned with 5 primary care providers have value upwards to $100 million in this new world, with fixed costs of $20 to $30 million. So rural has an incredible value in this new world to the extent we're aligned with primary care. And oh, by the way, that expense line, that blue line, just had a whole bunch of new costs added to it. And let me share with you what those are. Bricks and mortar, specialists, and technology all just became cost centers in that new world. So again, rural hospitals, to the extent they're aligned with their primary care, have incredible value in the new world. So if we do have value in this new world, we have to figure out how to get from the world of fee-for-service, this pillar on the left, that is stable. It's stable because our payment system and delivery system are completely aligned. As an accountant, the more you do, the more you make. The problem is, it's smoldering. It's somebody's, it's rotting out from the inside. There's a little fire on the top of it. And it's really starting to kind of fall apart based on our earlier conversation. And so we've got to start thinking about moving to this new world. To the far left, we have a stable platform. And in this stable platform, it's stable because you have 100% of delivery system aligned with 100% of payment. And it is the more we create health and reduce the demand for sick care, the more successful we are. But everything in between is a disaster as the fee-for-service comes down, goes down, and population-based payment substitutes in. You've got schizophrenia because you've got, some of your payer mix you want to maximize volume, some of your payer mix you want to minimize volume, and how do we do that? And so that becomes the shaky bridge that you've probably heard us refer to, or me refer to, or someone refer to, that we're talking about. Once you step out onto this thing, if we don't move to get across this, the longer we stay out in the middle, it jeopardizes our position. I really just want to focus on 2 more slides before I turn this over to Terry, because then the rest of the slides really just become an additional tutorial of what we do to deliver. So the next slide, and I think this is one of the most important slides in the deck here, this premise slide. And because this really explains how we got to where we got from a form, from a healthcare delivery system form, and what the new form is going to look like sometime in the future. If we go with the premise that form follows function, follows payment, finance, and we start thinking about the functional imperatives of a fee-for-service payment system, the true functional imperatives of a fee-for-service payment system was an organization if one organization could manage one's own price, what we got paid, our utilization, and our expenses, those 3 things, one could be successful. And so the form we got out of that, frankly, was we got a whole lot of ones competing with other ones on their own price, utilization, and cost. Now turn the payment system to a population-based payment system. There's new functional imperatives now, and those functional imperatives are kind of caring for a population of 20,000 people in our rural areas, or 15,000, or 30,000. You can't do that as a one anymore. We've got to create alignment with a tertiary system. We've got to create alignment with community hospitals, with ambulance, with home health, with public health, with nursing homes, home health. All these things become part of this equation around caring for the health of a population. In addition, we've got to aggregate scale if we're going to assume and diversify insurance risk. And so what the future really looks like is aligned organizations competing with other aligned organizations for covered lives based on value, as we just talked about, that new competitive driver, and also some new networking skills. And so I see the world quickly emerging where you've got the narrowing of not-so-narrow networks. You've got large systems like Geisinger, right, where integrated insurance function, provider delivery system, competing with University of Pittsburgh Medical Center, UPMC, with their own insurance product, acquiring hospitals all over western Pennsylvania and central Pennsylvania. This type of narrowing of not-so-narrow networks is very likely going to be how we're going to see this thing play out. This is the most important slide because if we know that the industry is moving, if we know why it's moving, we know that rural hospitals have value in that new world. Again, we've got to figure out how to get from here to there. This one slide, I had the Chief Medical Officer of the Georgia Hospital Association, when I was presenting this, he stood up and he said, Eric talks about a shaky bridge, but he said this transition framework, which we call this, is a concrete path for rural hospitals to move across this world of fee-for-service to population health. So, with that introduction from the Chief Medical Officer of the Georgia Hospital Association, give me a chance to explain it to you before you kind of dismiss. So first of all, going across the x-axis, we got the payment system, right? Form follows function, follows finance. We've got a payment system that's going to evolve from fee-for-service to, I'd say, accountable care light in phase 1, accountable care medium in phase 2, accountable care heavy in phase 3, and then full population-based payment out on the left. So it's a time measured by the kind of the percent of payers that are paying under some type of an accountable care payment formula. Okay, so now coming down the left-hand side, there are 3 strategic drivers. There's 3 strategic areas that we have to transform or create. First of all, the delivery system. The sick care model that we are today, we've got to make it more efficient, we've got to align with our revenue centers, and then we've got to ultimately take out big chunks of fixed costs in the new as we reduce the demand for sick care services. That's initiative 3. So the first initiative is, so we've got to transform our delivery system. The second thing we have to do is create a health system. That's the blue bar in the middle. We have to create a health system. We don't have one right now. Every one of our mission statements of our hospitals talks about population health and creating health in our communities. But if we did that really well, we would close our hospitals today in fee-for-service. What this is looking at is a kind of the specific things that we have to do to create a health system. And then the last piece is we have to move payment. We have to proactively pick up and move payment. We've got to take if we don't, and we do, we transform our delivery system and we create a health system, and if we don't proactively pick up and move payment, ultimately we will close as the insurers and the government thanks us for right-sizing ourselves. The last piece of this I want to explain is the orange bars. These are the strike points. So when the initiative, for example, phase 1, initiative 1 at the top of the delivery system, which is operating efficiencies, quality, patient engagement, when that initiative hits the orange line, we have to implement. In other words, the 71 rural hospitals that we've seen close right now have not been able to move fast enough. They have not been able to improve their operational efficiencies or quality and patient engagement as fast as the market's moving. The second initiative down is aligning with primary care. We've got to strike on that sometime in the future. And the important piece there is that that's the revenue centers in this new world. So let's start planning today, while we're in phase 1, how we're going to align with all our primary care physicians in that new world. And that's this phase 2. The third one is initiative 3, which we don't have to implement for a number of years. It may be 5 to 8 years before we actually have to strike on this. But this is coming together in larger regional systems, developing the strategy today to ultimately think about taking out big chunks of fixed costs, of which most are in big city hospitals at this point, because specialist technology and bricks and mortar, but taking out big chunks of fixed costs in this new world. Down on the bottom, moving payment, start with your own self-funded health plan. And if you're not directly self-funded, you're self-funded 1 year removed, as Blue Cross or your other insurers are just going to build in current year rates into next year's premium. The best part about self-funded plans with some type of a wraparound reinsurance is you get the claims data. And with the claims data, you can start to understand your patient, where people are spending their pharmacy, where claims are being incurred. You can understand your chronic disease, and you could build that all into the health system as we create that. That's something we should strike on today. Redesign our health plan. Create a value-based plan design. Kind of build in incentives for health. If there's smoking, additional premiums for smokers. Kind of start thinking about that. The second one is transformation payment models. This is like gain share models, like a Medicare ACO. Start planning today to move in the new world, to create a larger population to experiment with before we move to initiative 3, which is full risk plans. And that is something we develop a strategy with today, and it's very closely linked to the delivery system strategy in up above, the initiative 3, around developing scale and to be able to essentially take risk in the future, which we're not going to be able to do in our rural communities of 15 or 20,000 people. And then the middle, the creation of the health system. What this is about is really just saying, let's crawl before we walk, before we run. And in the end is delivery system, payment system, and health system all come in under one integrated organization called a provider-based health plan. again, if the premise of form follows function follows finance, this is the logical end result of that happening. And you can see the individual things, the strategies that we have to do in each of those that involve developing that health system. The beauty of this, and then I'm going to jump to the end, is really to say that the beauty of this model is it takes this concept of population health that seems so vast and non-particular, and it creates very specific strategies. It separates the sick care model, delivery system, the health system, and payment into buckets that we can actively manage our strategies. The second thing it does is it creates alignment. Everything that we do in phase one, everything that we do in that first column maximizes the fee-for-service world we're in today, but creates a pivot position to the phase two as accountable care payment systems come on more. Everything we do in phase two, once we get there, does not hurt fee-for-service, but further creates a position in this new world. And oh, by the way, if we don't get to that new world, phase three, if for whatever reason this thing backs up, as long as we haven't implemented phase three, that phase three, you're all in this new world. But we don't have to make that decision today. So, that's the beauty of this model. It allows us to think incrementally and making sure that we don't shoot ourselves in the foot in this heavy fee-for-service world today. The rest of these slides really are saying, how do we do it? What do we do specifically around efficiency? What do we do around, all the things around efficiency? And that slide's literally 25, 26, 27. What are the specific best practices critical access hospitals, small rural hospitals are doing? The cost reports on 28, all the opportunities within Medicare cost report. Staffing, this is a pretty decent, staffing metric. Benchmark your staffing based on departments. Understand physician practice management. Have an efficient operating or kind of organizational structure that allows you to compensate people, recognize performance, measure performance, hold people accountable, push decision rights down. All of this piece is an effective organizational design. Have high quality scores. Partner with your medical staff around quality. Increase your board members' understanding. Primary care line, a huge opportunity for us. And the most important thing we can take away from this talk is the future economic value of one primary care practice. It should change the way you think about relating to your primary care physicians today. If you don't align with them, there will be somebody come along with more capital and expertise that will align with your primary care physicians sometime in the future. And that could be a death of many rural hospitals. Service area rationalization. This is just the payment. We talked about a lot of the payment system and how we should move across this. And then the care management. What should we be doing today? And these initiatives here of patient-centered medical home, discharge planning, claims analysis capabilities, evidence-based protocols, all of these things that we should be doing today and we should be doing, it don't hurt fee-for-service. And so, I look at the end and say, hey, we've got a very different industry right now. We've got an industry that we're going from this competition on the zero-sum game of shifting the buck to a competition on true patient value. Costs are going to come out. Innovation is going to come in. We have got to figure out as rural hospitals how to cross this shaky bridge, and making sure that we don't get the healthcare system out in front of the payment system or the delivery system transformed before we create the movement in payment or health. All these things have to be timed closely. So what are the strategies? Increase leadership awareness of the new realities. The rural hospital toolkit, Terry's going to talk a little bit about that. That's an important source for you all. Have a bridge strategy. Have a shaky bridge strategy, a short-term, 3-year plan of how we're going to move in this direction. And then you can see some of these other things. So, I know we ran about 5 minutes over my section. Terry, hope you can make it up on yours, but I appreciate you guys listening and look forward to questions.
Thanks, Eric. And I just want to acknowledge, Eric, we've worked together for the last 15 years or so. This is a small rural hospital transition program, and transition means transition into value and population health. We're virtually certain that that's where the industry is going. I agree totally with Eric that the political conversations we hear are not largely relevant to where the industry is going. The industry is already partly there. And I think the good news is we've seen significant movement on the part of our rural providers, our rural hospitals in general. Now, what I'm going to tell you is first of all, I have to say that virtually everything that Eric has presented that I agree with. I think our center, Rural Health Innovations, agrees with. He's been kind of a leader in that regard for us as well. But we've done a lot of homework in terms of investigating, what has been happening in the accountable care organizations across the country. As Nicole noted, I'm on the board of the National Rural ACO, which has expanded significantly, so it now has hundreds of hospitals working with it. In addition to that, we conducted 23 informational interviews with early rural value programs to learn what we could on that. We basically worked with the major research organizations, the rural health research organizations, and then we have a ton of experience kind of working in the field with hundreds of rural hospitals over the years. We've provided technical assistance to well over 100 rural health networks, and we also support all 45 Medicare Flex programs. So this is kind of what we've learned, and we've basically taken kind of the lessons learned and put them into an implementation framework here, which we think nicely supports the framework that Eric's already talked about in terms of the transition into value. And so I'm going to be going over that very quickly. The concept here is that it needs to be pretty simple and straightforward. But in order to achieve that successful outcome on the back end, we believe we're going to have to manage some critical pieces. And we put this framework kind of based roughly on a Malcolm Baldrige framework because, to our knowledge, it's one of the very best frameworks that is out there. So we're moving into the triple aim. Eric's already talked about it. It's about better care, it's about smarter spending, and it's about healthier people, which are kind of the new terms that are being used right now. And here's my most important slide that I'm going to be giving you, and this is different than anything Eric has put in there. Look at the factors influencing health and well-being. And there's multiple, this is not one source. In essence, basically, as Eric talked about, if we're now going to be responsible for our populations, and remember now it's going to be our hospitals and our physicians that have to take on that financial responsibility as well as the quality responsibility. Look at the causal factors here as we look at this. Clinical care is a relatively small piece of the eventual outcomes. The other pieces include social and economic factors, the very behaviors of people in general. Clinical care is a part of it, but there's the physical environment and the genes and biology as well. If you take the genetics out of it, you're basically talking about anywhere between 10 to 20% of our population health outcomes are going to be determined by the clinical setting. So that has very important considerations here. As we start planning whatever the value-based models that we're going to be planning, we need to really keep this in mind. Now, what I'm going to talk about very quickly is we've suggested that there is a framework here. There are planks to be put down on this bridge to value if you happen to be a rural hospital. We're going to suggest that leadership is really, really important. One of the state hospital associations I worked with recently said, our boards of directors are our #1 issue right now. This was in the South, and in essence, there was the thinking on the part of the board members that Obamacare is going to end with the new administration, and that means we don't have to do anything, or we can go back to the good old days, which weren't all that good, if you'll remember. Totally support what Eric is saying about the medical staff. It's our observation and our work. I teach the medical school one class. Our physicians are not understanding what is happening. Eric has talked about the value of primary care and the importance of physician buy-in, but our primary care providers in particular are not aware of this new model, and there's education and awareness we need to create. And then finally, we've got to get our hospital leaders, our managers, and our care coordinators on board and aligned. It's really important that we don't go running off, after accountable care organizations or value models without understanding kind of the full picture, part of which Eric presented, and hopefully I'm going to present a part here as well. We need to build it into our strategic planning. Eric and I worked with a hospital recently that had just built this brand new hospital, and it was close to $30 million put into this hospital, and the space was not appropriate to the future. It was all about the inpatient side of it there. And so in essence, we've got to think this through. We've got to incorporate this movement into value, which has to be a careful consideration as we're moving out. But leadership engagement, involvement, and understanding is absolutely crucial. Partnerships, I know that the previous slide talked about how it's going to be other things. We're going to have to work with social services. We're going to have to work with others because we only have so much influence on the population health outcomes. So primary care providers at the top of the list. My number one recommendation, as well as Eric's, is you've got to make sure that is a tight partnership. I know of one national ACO that is creating ACOs with a primary target of signing up as many primary care providers as possible. And there's nothing wrong with that necessarily, but it is extremely important that hospitals at this juncture be a part of whatever these ACOs are, and the best way to protect yourself in that is to develop those working relationships with primary care providers. But it's also about long-term care. It's about mental health, it's about public health, and it's about social services. And there are resources out there, including businesses, churches, and government, et cetera. A lot of these folks don't understand this new value formula. And so we've got to engage them, we've got to use them, because in essence, we're now responsible for comprehensive care and wellness of this population, whether it's Medicare patients, Medicaid patients, Blue Cross Blue Shield, United Healthcare, Aetna are all moving in this direction as well. So looking at the partnerships with payers becomes another consideration. Not like the old HMOs, but looking at it with the providers in more of the driver's seat. And here's a slide that just says this is really a network. We're actually creating networks now that are community-based, including all of these other providers. For example, we have a network in North Carolina it's just made up of churches that are basically volunteering to bring patients in and doing helping to support primary care. Bunch of ants working together. It truly is this opportunity in a rural community to do things a whole lot quicker and hopefully more effectively than in some of the larger cities as well. Quality and operational and financial efficiency, we have to be as lean as possible. We can't afford to have inefficient revenue cycle systems. Customer service is now a part of the reimbursement formula under value. So it's everything that we can do to make our current processes and current systems as efficient as possible. Care management that's a key, that's the first thing most of the accountable care organizations get into. We need to create care coordination capabilities within our hospitals so that we can coordinate the comprehensive care of patients from entry into the system, into home care, et cetera. And that means we're going to do it from a teamwork approach. The old days of the primary care physicians doing everything is now changing into this more team-oriented approach. And as I said, we're enlisting other types of providers as well. Information management, easier said than done. As Eric mentioned, we have to have access. We're now getting access to this comprehensive data we actually know what our Medicare patients are doing if we're an accountable care organization. And what we're discovering in the National Rural ACO and elsewhere is there's a tremendous amount of waste going on in the system. There's a tremendous amount of room for improvement in terms of inefficiencies. But it's not just the gathering of that information. We're really going to have to know how to analyze the data and actually how to make it actionable as well. So those are like 5 planks kind of moving across this bridge to value, and we think these are really important ones, and you can't do everything at once, but there are certain things that are within this, and there are tools and resources to help you. One of those are available on our small rural hospital transition site. We are moving into the development of an entire portal which would provide resources, education, et cetera, for each of these planks. Another is mobile and telehealth technology. Telehealth is booming. The barriers that were there before are gradually and relatively rapidly being eliminated. We're going to look to patient portals to gain access to health records. We need effective hospital websites. Technology is going to be a big part of our future, and it's going to be especially important for rural hospitals who are going to rely on more online and distance education and online and distance support in general. Workforce preparation. One of the big mistakes we too often make is we implement things without explaining why. This is a massive change, and in essence, the staff can understand why. It's got to be about better patient care. I wouldn't put it around the feds say we have to do it, or this is how we're going to make more money, et cetera. This is about better quality, better care, and in essence, it is the formula for success to keep our jobs, et cetera. But the staff needs to be on board, and they need to understand it. Plus, there's going to be new value-based skills and knowledge needed, and staff again can serve as positive health behaviors. We'll use our wellness and education on the staff first, and then we'll move that out into the larger community. Community and population health management becomes this longer-term piece, is that in essence we're moving into this. We'll keep people well and prevent services. We're going to get the groundwork in place first. We'll start. It's pretty easy to start participating in wellness and population health initiatives in the community. And fairly soon, it's going to be of huge value to us on a business perspective as well, including the local businesses, all of the providers, et cetera, and engaging the patient and the patient's family in the care is going to be really important as well. So where are we going? To me, it's a great destination. It's scary in its own way. We're going to have to cross a shaky bridge, but believe me, the bigger healthcare systems have a big shaky bridge in front of them as well. This is not easy for them. It's not going to be easy for you as rural hospital leaders either, but it is going to lead to a healthcare system that improves patient health, patient outcomes, et cetera. And we strongly believe that rural healthcare can lead the way. One of the things I would note is that the latest round of accountable care organizations had a majority of the new ACOs being rural. And so we've got a laboratory here that is going to be fascinating to watch as we move forward. And we're suggesting that there are a lot of tools and resources that we're happy to help with as you're moving forward. So if you're not moving, this is one of my favorite quotes by Will Rogers. Even if you're on the right track, you'll get run over if you just sit there. We cannot afford to sit there. I assure you, we're not going back to the good old days, which, as I indicated, we're not all that good anyway. This sets up a new range of challenges, and we still have some of the same challenges as before. But I'm very convinced that if we get moving if we're thoughtful about how we do it, and if we really understand where we're going, the value of partnerships, et cetera, that we're going to reach that destination across the shaky bridge. So with that, I know we're close to the end of time. If you send your questions in specifically to us, either to Eric or to me or to both of us, we will answer them individually. So I can promise that. And also, if you would, please complete the short online assessment that is there. And again, if you're not familiar with our organization and the really wonderful resources that have been made available through our federal contract, we certainly encourage you to do that. I want to thank our speaker, Eric Schell. I want to thank all of you for being a part of this webinar. And again, I want to be as encouraging as possible in this. There is light at the end of the shaky bridge, and we really hope you use us, and we'll be as valuable as we possibly can be in your transition kind of into the future. Thank you very much, and I look forward to getting some of your questions. Bye.
Thank you all for a great webinar today. The recording of this webinar, along with